So there are lots of challenges to disseminating evidence-based treatment for PTSD and evidence-based treatment in general. And I think that among the most important challenges and maybe barriers is really the culture of psychotherapists. What did they learn in school? What's their attitude towards psychotherapy? How do they perceive psychotherapy? So most psychotherapists are perceiving psychotherapy is an art, is kind of a talent that the therapist has in connecting to the patient and help the patient kind of understand themselves. So, many therapists, when they go to study psychotherapy, are looking for connections with the patient, understanding the patient, help the patient understand themselves. And it's a very different concept than evidence-based treatment. In evidence-based treatment, you're targeting symptoms, post-traumatic stress disorder, or you're targeting diagnosis, or you're targeting an illness or a problem like depression, PTSD, panic disorder, and your aim is to reduce as much as possible those symptoms and to encourage as much as possible the functionality, the ability of the patient to function. And that can be actually quite boring because you kind of follow a prescription, so to speak. At least it is perceived by many therapists, more conventional therapists, more traditional therapists, as curtailing their ability to use their own intuition, what to do with the patient. So that's a big barrier. Second barrier are the system in which the therapists work. And the systems many times reward the number of patients that you see, rather than how many patients have you cured. So, for example, in the VA or in the military, psychotherapists are seeing their patients maybe once a month because they have so many patients and the burden is so high that they can't really see patients every week. Whereas the evidence-based treatment like prolonged exposure require once weekly. So on the long run, using evidence-based treatment is cost-effective because the treatment are short. You give 8 to 15 sessions of treatment. Patients becomes much better and they need less to use the system. If you look within a year, those patients that receive prolonged exposure, for example, go on to request much less mental health help after getting PEs and before getting prolonged exposure. But if you just look in a week of productivity, then you can see that if you do PE, you can only see maybe 15 patients, maybe 30 hours and 15 patients to 20 patients. Whereas if you do other treatments that require only 45 minutes or 30 minutes, then you can see 40 to 50 patients. So it looks like it's very productive. On the other hand, if you look what happened to the patient after a year, you'd see that patients that don't get evidence-based treatment are less well off and therefore require the system. So it requires change in how systems view treatment, and it requires a lot of change.